Good afternoon and thanks for joining us. I'm Judy Simpson. Today we're focusing on an aspect of our healthcare that's getting more attention than ever. It's called health economics. My guest is a scientist and an economist. He's a professor of surgery and of economics at the University of Vermont. I want to welcome Chris Jones. Chris is the director of the Global Health Economics Unit in UVM's College of Medicine. Thanks so much for being with us.
Thank you, Judy.
So what is health economics?
Yeah, very good question. So health economics is about improving outcomes and reducing costs. We're no longer in the Garden of Eden. Our resources are limited, and so we have to make an efficient choice of how best to utilize those resources.
Isn't this kind of sort of a shift in philosophy? Because it always has been in the past. Do whatever you can to save the patient no matter what.
Right. And I'm not saying that that should be gainsaid. I really feel that we should do whatever we can for the patient. And so what is health economics not? Health economics is not about cutting budgets. It's not about giving patients substandard care. It's just about bringing transparency to the cost of what it takes to give the best care to patients. So I actually brought in a couple of slides. I hope that's all right. I was thinking that we could actually give our audience, a viewing audience, a couple of examples. And so, you know, in this example we have in treatment A and treatment B. Treatment A could be radiotherapy and treatment B could be chemotherapy, and chemotherapy is more expensive. So in this case, it costs an extra $10,000 to achieve an additional year of life. Well, you know, some people would say, well, you know, are we just going to go with the cheapest option? Absolutely not. Here we're saying that additional $10,000 that achieves a year of life may well be worth it. And so it's a policy decision really as to whether it is. It's up to the patient as to whether it is, up to the doctor as well. But in this case, you know, I would say that a year of life would be worth $10,000 additional dollars. Now, the question then becomes, is it a healthy life?
Right. What's the quality of life?
What's the quality of life? So, as we see in another slide here, we have quality adjusted life years. Now, those are not allowed to enter the picture under the Affordable Care Act yet. They certainly do enter the picture in other countries, other single payer countries. And we see that in the case of quality adjusted life years, those are a function of the length of life left multiplied by the patient reported quality of life. And that's on a scale from 0 being certain death and 1 being perfect health.
And so people will be able to make those kinds of decisions themselves with their doctors?
I think that patient engagement component is going to become increasingly more important because at the end of the day, Judy, does it matter? I mean, if you're going to have an extra 2 months of life, don't you want those to be really quality months? Right. And I don't think the cost really enters the picture there, but I think that the quality component should enter the picture, much more than the cost.
And so this is the type of analysis that is becoming more and more common in the news now.
It is. I've got one other slide that I wanted to show you just in terms of health economics as a field. We've had about 1,000 publications per year, over 35,000 publications to date. So it's certainly getting out there as something that's important. And I think it's important just because we don't have enough in our budget to cover healthcare, defense, and everything else that's needed.
And so what is the Global Health Economics Unit, and how did it get started, and how did you get your start?
Thank you. So the Global Health Economics Unit is a homegrown initiative. It was set up by Dean Morin at the College of Medicine. He brought me on board to create this health economics competency, firstly so that we could look at what's happening in the state. But our center is not our perimeter. We're looking at efficiencies and ways to improve outcomes and reduce costs within the state, but also in other settings and even in other countries. So we've got collaborations now around the world.
And so who else are you working with? What are some of the topics?
So we're working with the Green Mountain Care Board on pricing variation. We're working with a couple of company sponsors, trying to find out, you know, how do we test the efficiency of their drugs or devices. We're on, let's see, we've got 3 NIH awards, 2 that have actually been issued and 1 that's in the pipeline, looking at incentives. And this is Professor Steve Higgins that looked at actually, can you drive healthy behavior by incentivizing it? And what we find out as humans is that we're very present in the here and now. And if you short circuit that, you can actually achieve meaningful results. And let me give you an example of that. So women who smoke, particularly during pregnancy, create all sorts of problems for their infants. And all sorts of costs obviously ensue in terms of lifelong, potentially lifelong disabilities and susceptibility to chronic disease.
Right.
If you give a nominal incentive that short circuits that very present here and now, the need, the desire to smoke, $5–10, it actually drives healthy behavior. And if you can do that over the course of 40 weeks, great results. So we're testing that in the laboratory setting.
So rather than paying when things go wrong, pay up front to prevent them.
Yeah. It's a philosophy change. Some people wouldn't want to reward healthy behavior or incentivize against doing the bad thing, but we really see that it works.
And so, can you also give me another example of how that would work?
So opiate dependency is also a big problem. So I'm deliberately mentioning the substance misuse because I think that's a real Vermont problem. And in that case, neonatal abstinence, which comes from mothers who are, when the baby's in utero, taking either prescription opiates or illicit opiates, those babies have to be weaned because they become addicted to the heroin or the methadone. And in weaning them, that costs $2,000 per baby per bed day. That's astounding.
Yeah, as a matter of fact, I think part of what you're doing too is to bring to light what it does cost when you do get sick. I think people are really surprised to find that out.
Yeah, and having that transparency, or at least being aware of it, I'm hoping will lead to mindful changes.
And so what's happening in Vermont at present, and how can health economics help our chances?
Yeah, so here we have Deb Richter's spearheaded single-payer system and the governor's single-payer healthcare initiative that we're driving towards. We're not there yet, but we're certainly driving towards that. And that's supposed to improve efficiency. It's going to eliminate some of the red tape and actually lead to everyone playing in the same sandbox towards the same common goals. An ounce of prevention, pound of cure, really focusing on that preventative side of things, engaging the patient, making sure that they're a participant in their whole healthcare process, and then engaging so-called community healthcare workers as part of the patient-centered medical homes. So I'm hoping that kind of back to those drugs misuse examples and incentives that can drive healthy behavior, that combined with the community healthcare workers, folks who are getting out into the homes of these patients and coming from their same communities, will lead to those healthy changes. It's going to take more than a year, more than two, probably an entire generation, but I think that will make Vermonters the most healthy in the nation.
Well, it seems to really just make sense.
Thank you. It makes dollars and cents.
Yeah. What is the cost predictive space, and how does that help patients? I know that was another issue that you wanted to talk about.
Yes. So we created a homegrown initiative here. We called it formyodds.com. It was initially a fertility predictive algorithm. And what we found was that, well, we can predict which women are likely to take home a baby following fertility treatments and reduce the risk of multiple births. If you put back too many embryos, build the house too high, it topples. Too many embryos leads to too many multiple births. Those are always born cesarean section. They end up in the neonatal intensive care unit. That's expensive. So that same philosophy now we're taking to other disease areas, cardiovascular disease, in terms of open versus endovascular aneurysm repair. We're taking it now to cancer. And what we're finding is that the average patient is anything but average. There are many unique circumstances. Our needs, wants, aspirations, and prior treatment experiences, as well as our attitudes to those treatments, really affect what treatments are right for us.
So doesn't that make your job harder?
It does. It adds a level of complexity. So we're collaborating with something called the Complex Systems Spire at the University of Vermont and engaging these experts in complexity so that we can really address the individual needs of the patients.
And so how is this good for patients?
Well, I think I don't want to be treated as an average patient. I want to be a unique patient. And so I would also be very comfortable understanding what are the cost implications that I'm presenting to the system. So from my perspective, at least, and it's very easy for me to sit here and talk about other folks, but at least from my perspective, I think that I want treatments to be more individualized, more personalized, and I want my best outcomes in the most efficient way possible.
And so what exactly does this model tell you?
At the end of the day, it puts outcomes alongside costs, which is going to become an increasingly big issue because hospitals are going to be reimbursed in a way that's tied to the outcomes, tied to what's called this triple aim initiative, the improvement of health of the population, the improvements in treatment experience as reported by the patients, and reductions in cost.
So this is going to really require a lot of patient participation, which is, in the past, hasn't really happened. I mean, I think in the past anyway, when you get sick, you go to the doctor and then you just rely on what they tell you you should do.
Exactly. And that may still be the case for those patients who are receptive to it and who feel that, doctor, I want to know what's best for me. But for those who want to take an active locus of responsibility for their own treatments, their own health, and the health of their families, I think that is the tipping point.
And to say that what you do and how you live your life can have a profound effect on the outcome of what happens later in life. I think, we're all so caught up in our lives, and we know we shouldn't smoke, we know we shouldn't be drinking, we know we shouldn't be doing drugs, and yet that all still happens, thinking, I'm not going to get old.
Everything in moderation, including moderation.
And so, is there anybody else doing this?
There are. There are a number of companies that are out there doing this, mostly spin-offs from universities. But we're the first to be in this predictive space at the individual level. And that means we take a bunch of data from a lot of patients, so-called medium-sized or big data. We then synthesize that data so that we can predict for an individual new patient coming in, what are their chances going to be, and what are those costs looking like.
And so is this something that doctors are going to be embracing?
I think they are. I mean, certainly within our Department of Surgery, 88 faculty therein, at least now, we're expanding. I think that most of those, if not all of them, will embrace this technology that will increase patient engagement, reduce cost, and allow for the best treatment options to be available for their patients, which is the most important thing.
Right, of course. So we have about 4 minutes left, and I know that you wanted to talk about the economic impact of cancer because that's very huge.
Yes. So the economic impact of cancer is a really big deal. It's expected to exceed cardiovascular cause deaths by 2040.
Wow.
So we're very good at treating hearts, and the last 10 or 20 years have shown that, but now people are dying from other things, namely cancer. And within cancer, we've got colorectal, we've got breast cancer, and we've got lung cancer, which is the #1 killer. So we've already touched on the lung cancer and how important it is not to smoke.
Right.
But it's also equally important that we address those patients, in the most humane way possible and with dignity. And so, within the smoking leading to lung cancer paradigm, we're finding biomarkers that might lead to early intervention. And that's very interesting. But you asked about the cost, so let me address that question.
Yeah.
So it costs about $200 billion a year to treat cancer.
Wow.
It's astounding.
Yeah.
I've got a slide here that just shows that there's hope. So for those in the audience, who have experienced cancer or who are likely to experience cancer over the next 10 years, it's actually going to be a very good time for us, because 31% of the current research and development funding is going towards oncology and immunomodulation.
So that's very good news.
I think it's very good news. It's very bad news for those who are relying on vaccines, antibiotics, and other sorts of areas that are just not getting enough attention. So that's something that certainly should be touched upon very, very soon. But cancer is very good news.
Well, and that's because, that's a whole nother piece of the pie is research into medications for these kinds of things. Pharmaceutical companies obviously are going to be looking at what they can make the most money on.
That's right. So there should be a business decision around investing money and getting a return on that investment in anything that the drug companies are going to delve into. But the fact that more generics are out there is also very encouraging. The fact that patients experiencing rare diseases are afforded special protections, that's also, I think, very encouraging. So I think this is a very good time to deal with illness. I think that we're all going to be approaching our maximal life expectancy of about 110 years.
Wow. Really?
But in terms of how long it will take to get there, it may take a decade.
And so someone who's maybe 50 should now be thinking, well, I got another 50 years to go, so I need to really, get myself in shape and stay as healthy as possible.
Yeah, or focus on the next generation, which is what I'm doing. So investing in our kids, making sure they're aware of the consequences of smoking, making sure that that 40-week pregnancy is safeguarded, and making sure that, we're able to give nutrition and food security and all sorts of other important areas the due attention.
And one of the things that you have studied too is the indirect mortality cost, which is interesting.
Yeah, so economists have placed a value on the human life at around $300,000 in the Western world. And that's not because everyone makes that amount, we certainly don't. But it means that that's our impact, that's our influence in our wider communities. So when someone is ill and unable to get back to paid work, it's much more than their immediate salaries that are at stake. It's their ability to influence, to be a caregiver in some cases. It's their ability to be integrated in the community and to have that functional mobility that is all important.
Who should be paying attention to this kind of information?
I think all of us should be paying attention at very different levels. I think in schools we should be taught more about taking ownership over our health. I think that that's really a great starting point. I think in colleges we should be understanding more about the consequences of engaging in things that are risky or not healthy. And we've seen this with the human papillomavirus vaccine and what's happened to a number of stars in the media who've experienced this. Michael Douglas, Pierce Brosnan's daughter, daughter and so on who have experienced cancers. And these are areas that really should be embraced as opportunities for intervention, opportunities for education.
Well, that's excellent. Well, I want to thank you for joining me today. It's just a fascinating discussion and putting the pieces together, and it makes perfect sense, and so thank you for your work.
Thank you, and I just wanted to say that health economics is not as scary as it seems. We don't make the decisions about cutting budgets. We're interested in, how do we get the best bang for our buck.
Thank you so much.
Thanks, Judy.
That's our program for today. I'm Judy Simpson. We'll see you again next time on Across the Fence.
For a video copy of today's program, call toll-free 1-888-ATF-3430. Across the Fence is brought to you as a public service by University of Vermont Extension and WCAX-TV.